I'd like to welcome everybody tonight to the newest endoscopic therapy and treatment for bariatric and gastroesophageal reflux disease. My name is Brian Davis, and I'm Associate Professor of Surgery and Internal Medicine at Texas Tech University Health Sciences Center in El Paso, Texas. We have a great panel of speakers available for you tonight, to include Dr. Bipan, who is an expert in the restorative operative surgery endoluminal therapy or ROSE procedure for revision of bariatric surgery. Our second speaker tonight will be Dr. Michael Ujiki, talking about the endoscopic sleeve gastroplasty. The third will be transoral incisionless fundoplication by Erik Wilson from UT Houston, followed by the final speaker, Dr. Jeff Ponsky from Case Western University Hospitals in Cleveland, Ohio. Just to start, we'd like to talk about making this discussion an interactive broadcast with discussion from participants. We can encourage you to use the chat pod located in the left hand of the screen to type your questions and comments to the panel of experts. If you lose audio or video feedback, please exit the webinar, close out of your browser, launch your browser again, and log back into the show. If problems continue, you can restart your computer. At the end of the show, there will be a link to the SAGES survey, and we encourage you to take the survey in order for us to make upcoming events better and improve this production. The show is being recorded and will be available online at SAGES within the next 2 to 3 weeks. The critical importance of innovations in endoscopy start with the critical role that surgeons have played in endoscopy. Many people do not know that the colonoscope was introduced largely into the use in American medicine and surgery by Dr. Wolf and Shinya at Beth Israel Hospital in New York City in 1969, with report by 1972 of the first snare polypectomy during colonoscopy, followed shortly by innovations by Dr. Jeff Ponsky into the first true transoral incisionless surgery, the peroral endoscopic gastrostomy tube, which we use commonly today, reported on in 1979. Doctors such as Dr. Ponsky and Vitale have been pioneers in using endoscopic retrograde cholangiopancreatography for treatment of bile duct stone disease and treatment of chronic pancreatitis, and has created a generation of surgical endoscopists that have really opened the gateway to surgeons dominating endoscopy and leading to intervention such as the peroral endoscopic myotomy, which was created by Dr. Haru Inoue from Japan and has been taking off as a treatment for achalasia here in the United States. It should be noted that there's also been several other great innovations in endoscopic therapy, to include the endoscopic cystgastrostomy, which has been pioneered partly by my mentor, Dr. Vitale, with strong leadership by surgeons in surgical endoscopy. It should be noted of critical importance is the development of surgical skills in endoscopy to include recent training in fundamentals of endoscopic surgery, which has really been pioneered by Jeff Marks at Case Western Reserve and under the leadership of Dr. Jeff Ponsky, to really teach graduating chief residents the fundamentals of endoscopic surgery and help maintain that skill base so that we're able to continue to pioneer as surgeons in an evolving world of endoscopic therapy that really creating innovative treatment options for complex diseases of the upper gastrointestinal tract, which we'll review today. I'd like to give a special recognition for the large participation from Abington Memorial Hospital outside Philadelphia, to Morehouse Medical Center, to the Medical University at Case Western Reserve Hospital program, and to one of our newest residencies, the UT Rio Grande Valley program, which has multiple residents participating. I'd also like to recognize my own residents at Texas Tech that have been well fed for this presentation. I want to thank everyone for participating. We have over 115 participants tonight, a great lineup of speakers. To begin with, I'd like to speak about the background of Dr. Bipan, who is at Loyola University Medical Center as the director of the Loyola Center for Metabolic Surgery and Bariatric Care. He's also the director of surgical endoscopy and the division director for gastrointestinal and minimally invasive surgery. He is an accomplished innovator, having several patents in fields to treat Barrett's esophagus and with endoscopic interventional access devices. Welcome, Dr. Chan.
95% of patients maintain at least 50% excess weight loss and up to 14 years of follow-up. However, we do have gaps in weight loss and efficacy in all these current procedures, including the gastric bypass, sleeve gastrectomy, as well as the adjustable gastric banding. Gastric banding is less than 1 to 3% of bariatric operations. Sleeve gastrectomy has taken over the gastric bypass and is approximately 60% of bariatric operations done in the U.S., and the gastric bypass is approximately 40%. If you compare these to medical therapy, 5 to 10% excess weight loss with medical therapy, gastric surgery in general is still predominant. However, there's still a gap between our medical and surgical therapy, and endoluminal focuses are there to help decrease or improve weight loss with decreasing morbidity. Post-operatively, patients that have gastric bypass do have suboptimal weight loss. If you look at significant weight regain, we typically say patients should achieve 50% excess weight loss at 5 years. However, patients are prone to having weight gain of 10 to 20%, and there are a lot of anatomic abnormalities that can precede this, including enlargement of gastric pouches as well as enlargement of gastric rhinostomies. If you look at the literature on open bariatric operations or open revisional bariatric operations, they have been shown to have increased morbidity, including high complication rates up to 15%, as well as mortality rates still reported to be as high as 2%. Laparoscopic reoperations for these patients are also being commonly done. However, these can have prolonged operative times as well as a significant morbidity. So if you think about a bariatric patient, particular patients that have had gastric bypass, I think it behooves all endoscopists to look for potential failures in patients. And studies have been reported at looking at patients that have weight recidivism or weight regain after gastric bypass. And if you study these patients, about 3/4 of patients will have abnormally dilated pouches as well as abnormally dilated stomas. And so revisional procedures, especially if they can be done through endoscopic means, can promote increased weight loss. Looking at the difference in sizes of the pouch or the stoma and predicting the weight loss after gastric bypass, the study that we performed at the Cleveland Clinic looked at patients that had good outcomes as well as that had inferior outcomes. And what we did find that both pouch and stoma do play an important role in affecting weight loss. But however, if you look at what is the predominant factor, we found that patients that had abnormally dilated stomas had a greater degree of abnormal weight gain compared to an abnormally sized pouch. So trying to limit the size of the stoma to approximately 1 to 2 centimeters, which is what we consider to be optimal, has shown to have a greater degree of success in gastric bypass. Also, if you look at some of the responses of endoluminal procedures and how bariatric surgeons in general perceive the response to endoluminal therapies in promoting additional weight loss, if you look at a risk-benefit profile, most bariatric surgeons would be able to accept a weight loss of an additional 10 to 20% with a procedure such as an endoluminal bariatric procedure having a risk very similar to a therapeutic endoscopy such as a polypectomy or a PEG procedure. So endoluminal therapies do not necessarily need to achieve the same degree of weight loss as a bariatric operation, especially if you're able to promote additional weight loss. So what are the therapies that we can offer our patients endoluminally? There have been studies looking at various different sclerosing agents such as sodium mauryate. There have been studies looking at some of the older products such as the Endoscopic suturing device, which was produced by Bard, as well as some of the other therapies such as the Rose procedure, as well as the procedures as listed in this slide, including the flexible EndoStitch device, the Stomaphyx device using H fasteners, some of the larger clips such as the OverStitch clip, as well as the current version of the suturing device being the OverStitch or the Apollo suturing system. If you look at utilizing some of the sclerosing agents, this is a very simple procedure. This is using a standard endoscope with a standard sclerotherapy needle and injecting various amounts of a solution trying to promote a scarring within the submucosal layer. This study looked at close to 30 patients that had undergone gastric bypass and then them undergoing a sclerosing in various different sessions. And they were able to achieve a significant diameter reduction down to that area of 1.2 centimeters, more or less. And those patients that had this therapy, 75% of their weight that they had regained after their nadir weight loss was able to be lost as well. So we're using sclerosing therapy has been shown to be beneficial. A similar study achieving a greater degree of a diameter reduction as depicted in this study. So this is what sclerosing would look like in a pre and post injection. You can see the diameter of the stoma here, approximately 2 to 2.5 centimeters in size. After injecting a sclerosing agent within the submucosal layer, relatively easy, straightforward, with relatively few complications with this type of therapy. Some of the more suturing devices that have been on the market were originally used for anti-reflux procedures, are depicted here with this Endocinch device. This device was then utilized in trying to do stoma reduction in patients that had weight recidivism after gastric bypass. In this procedure, and close to 80 patients that were followed for greater than 6 months. The suture placement was technically successful in close to 80% of patients, and patients were able to achieve some benefit in weight loss of close to 5% total weight loss compared to a sham group of just under 2%. And these patients, once you're able to achieve these sutures into this deeper layer, you're able to achieve greater degrees of suture staying in place over a longer duration. And the Rose procedure is depicted here is a much more complex platform. This device utilizes a platform that essentially mimics an over-tube, where the endoscope is utilized as the eyes for the proceduralist, and going through this very complex channel. Using a more complex and more robust anchoring system, we're able to plicate greater degrees of tissue with more likelihood of getting full thickness application, not just through the serosa, or excuse me, not through the submucosa, but into the serosal layer. This type of therapy was investigated in patients undergoing gastric bypass, and in this small study through multiple different sites, the gastric pouch was successfully accessed, and anchor plication was done in 80% of patients, and success was typically measured as being able to deploy anchors into the gastric retinostomia site. And you can see a reduction of the stoma in patients went from 2.8 centimeters down to close to 1.3 centimeters, so it was about a 50+% reduction in the size of the stoma. And in a larger study, close to 120 patients, using the Rose device in a multi-center registry, technical success after having utilized it in multiple patients was close to 100%, and all of these patients were able to achieve a 50% reduction in the size of the stoma, as well as some attempts at reducing the size of the gastric pouch as depicted here. Attempts were also made at plicating the side of the pouch itself, and patients in the short-term follow-up were able to achieve approximately a third of the regained weight that they had. Flexible endoscope, this is a version of what was done by Covidien, very similar to the Endoscopic device. This unfortunately is not commercially available, but utilizing a flexible shaft and the endoscope as the eye, the endoscopist is able to plicate the tissue circumferentially around this dilated stoma. A more simpler device is the Stomaphyx device. This allowed the placement of these H fasteners, which were permanent polypropylene-like sutures. These were essentially a suction-based device that would fit into a working channel of an over-tube, with the endoscope as being the eye, and being able to pleat the gastric pouch as well as the gastric retinostomy in this H-type of fastener. This was studied in multiple different centers. A publication from the group at Ohio State showed as time went on, patients were able to achieve weight losses with a small study, but patients even up to 1 year of follow-up were able to achieve approximately 10 to 20% of their regained body weight. With the depictions, as you can see, a pre-Stomaphyx device and then a subsequent post. Not only do you have a reduction in the size of the stoma, but also the gastric pouch itself is being reduced in size. Some of the newer, larger clips that we do have now available are these over-the-scope clips. These are nitinol clips that are mounted to the end of a endoscope. They're various different sizes. The concept of these are also very straightforward, very analogous to a band ligator that is utilized for variceal banding. In this study, looking at close to 100 patients after a gastric bypass where they had 10% of their weight regained. These patients underwent this procedure all under general anesthesia. Again, dilated stomas. In this study, the mean stoma size was 3.5 centimeters. Clips were applied around the stoma, and at 3 months of follow-up, patients were able to have a BMI drop from 45 pre-procedure down to close to 30. After 1 year, the BMI was down to 27 kilograms per meter square. These are the devices, again, very simple. That is placed on the channel of the endoscope. This is on the outside. These larger, almost bear claw-like devices are then able to be approximated, tissue approximated within the channel, and this device is then able to reduce dramatically the size of the stoma. The last is the OverStitch device, a very complicated endoscopic suturing system. This is also mounted on a therapeutic scope. This small study looked at 9 patients that had stomas over 26 millimeters. They were all able to be technically reduced down to 10 millimeters. In the short-term follow-up, these patients also were able to achieve approximately 10 to 20 pounds of weight loss. And this is a depiction of that device. This is an older version of that device, but it uses a very similar to a surgical needle with a curved apposition through the tissue, allowing for a greater degree of tissue purchase. So I think the future of endoluminal therapy, as you will hear from the subsequent speakers, is very robust for bariatrics, not only in restorative therapy, but also in primary endoluminal therapy. So I welcome a discussion. I think it's also important to remember that patients that undergo bariatric operations, it's important to look for mechanism and technical failures in their procedures. And for gastric bypass, it's still the gold standard operation. We should always be looking for sizes of stomas, pouches, as well as attempts at endoluminal abilities to reduce these, as well as eliminate potential fistulas. Again, we all know weight loss and weight gain is multifactorial, and utilizing these therapies in a total approach, including the behavior dietary modifications, is also important. And I do believe that having a appropriate time of intervention from the index operation may be crucial in delaying weight regain. Thank you very much.
Thank you, Dr. Chan. That was an excellent talk. I'd like to engage with the audience, and please indicate in your chat boxes any questions. Probably the first question I would have, Dr. Chan, is what is the long-term durability of some of these therapies? Obviously, I think the OverStitch with a larger purchase would have longer-term follow-up and better durability, as opposed to some of these other therapies like the Stomaphyx that may experience breakdown and mucosal sloughing.
Brian, I do agree with that as well. I think as you've seen, these devices continue to become more robust, from the simple sclerosal injections into the submucosal layer to these over-the-scope clips as well as, like you stated, suturing devices. I think the durability is still in question. I think what we should be thinking of is repeatability in many of these devices. Obesity, as we all know, is a chronic disease, and I think as such we need to continue to tackle this disease. So an operation by itself is not necessarily definitive. I think like many other chronic diseases, we need to look at different devices that continue to try to reestablish the anatomy to what we determined to be as best possible.
Thank you. I'd like to recognize Amir Arye, who is asking a question about complications of different endoluminal procedures, specifically an increase in marginal ulceration. And I say that definitely with the sclerosant type therapy, because some of these therapies obviously have a greater incidence of complications than ulceration.
No, I agree with that as well. I think what we have to be careful of is the foreign body reactions that many of these devices can also cause. As we all see with patients that undergo the bariatric operations of the index operation, sometimes the foreign body from soap sutures or other permanent sutures can lead to a marginal ulcer. So I think you have to be aware of that. I think some of the more inert devices, such as these nitinol-based clips, have a tendency to cause less of an inflammatory reaction. However, any of these devices can have a complication of foreign body, such as a marginal ulcer. The overall complications of endoluminal devices are going to be what we expect, from perforations to potential bleeding. I think for the endoscopist, it's crucial to make sure that these are treated as true therapeutic procedures, and taking all the safety precautions such as airway protection. Many of these are done under general anesthesia. Many of these are done utilizing CO2, and many of these are done in an environment such as an operating room or a true endoscopy suite that can provide all of those safeties.
Great answer. Thanks again. With your experience, do you have an experience with the endoscopic management of complications that occur after these therapies, such as stenosis of the gastric jejunostomy or perforation as well?
I have had those. I think for the stenosis, those are relatively easy to manage. I think it's important that you're capable of doing dilations using either CRE balloons or bougies. I think it's also important that if you do have a complication such as a perforation, the surgeon is able to recognize that. More often than not, these can be also treated with various other endoscopic modalities such as stenting, or even using a suturing device if you lead or run into bleeding as well.
Dr. Ujiki has mentioned, what would you call your goal and stoma diameter, and how would you measure that endoscopically?
Yeah, I think the goal of the stoma should be in that 1 to 1.5 centimeter range. I think 2 centimeters is somewhat dilated. The way I measure my stomas is using a snare, a simple polypectomy snare. Most GI labs have various different size and configuration of these snares, from a round configuration to an oval configuration. I think that's a very simple way of measuring it. I typically, my snare of choice is a 15 millimeter round snare, because that gives me my ideal stoma size. So once I place a snare through the working channel of the endoscope, I'm able to deploy it and then line it up against the stoma itself. And if it looks like it's less than that 1.5 centimeters, then I would say it's a normal size. If it's any bit larger than that, then I try to determine how much larger it is. So I think using a snare is an easy way of doing it.
Great, thank you. Dr. Ponsky from Cleveland wanted to know if you've used the over-the-scope clip for closure of gastric fistulas with communication between the initial pouch and the remnant stomach. and what your success rate is.
Yeah, I have done those for not gastrogastric fistulas, but for gastric leaks after both bypasses as well as sleeve gastrectomies. They work very well for a leak into the abdominal cavity. I think for a gastrogastric fistula, I've attempted that. I think the difficulty in the gastrogastric fistulas more often than not is they are along non-divided staple lines from prior open bypasses. These fistula tracts are relatively short in nature, and it's typically very difficult to reapproximate the tissue because of the staple line. The pliability of the gastric tissue is not as great. So my treatment of choice for these gastrogastric fistulas is to surgically divide them rather than try endoluminal therapy.
Great, thank you. There's Lava Patel who mentions, what timing do you typically see in follow-up for the patient who may require this therapy following the Roux-en-Y gastric bypass? In other words, where do you see the plateau develop in your follow-up phase?
Yeah, so I think that's one of the most crucial things that we should look at, in particular when you look at the studies that have looked at endoluminal therapies and various different attempts at trying to regain or jumpstart their weight loss. I think the optimal timing is probably within 2 to 3 years post-bariatric surgery. I think if you wait longer than 5 to 7 years, once they've had a significant weight recidivism, your chance of success is going to be lower. And we studied that in close to 100 patients that were post-bariatric surgery, in particular gastric bypass. We looked at various different endoluminal interventions from all the ones that I presented, and what we found was that the timing of the intervention was probably the most important thing. So I think most patients after gastric bypass show weight stability at approximately 12 to 18 months post-bypass. I think if you have a patient that does not achieve that target excess body weight loss of 50 to 60% at that time, then you should investigate them for anatomic abnormalities. And I typically recommend both an upper GI as well as a upper endoscopy. On an upper GI, you can determine if they have a fistula. You can also see how rapid the emptying of the medium is through the gastric pouch. And then an upper endoscopy allows you to insufflate and see the size of the pouch and the insufflation and a better size of the stoma. So I think 18 to 24 months, you should have a patient that achieves that 50 to 60% excess body weight loss. If they don't achieve that, then it's time to do an investigation. And then it's the time to do an intervention early rather than later. So I think 5 years is too late. I think ideally that 2 to 3 year time frame is what you should shoot for.
Great, thank you. I'd like to thank everyone for the great questions and interaction. The next speaker will be Michael Ujiki, who is Associate Professor at Northwestern and faculty at North Shore University Health Sciences Center in Evanston, Illinois, outside of Chicago. He's also the Director of Simulation, completed his education at Northwestern University, and trained with Lee Swanstrom at Legacy Health System in Oregon. Welcome, Michael.
Put together. Thank you, Brian. It's a wonderful program you put together, and it was great listening to Bipan. I'm going to be talking about endoscopic sleeve gastroplasty, so something that Bipan alluded to in terms of primary surgery for obesity. I do have these disclosures, but they are not relevant to what I'm talking about today, although I will be talking about some devices from Apollo. So when I look around Chicago, I see a lot of morbidly obese patients, and it always amazes me because we have amazing bariatric surgeons all around, like Bipan Chan and Dr. Bashan at U of C, Dr. Nagel at Northwestern, and so forth. And why is that? Well, the reason is that even though we have demonstrated a positive impact through bariatric surgery on obesity, really only 1% of qualified patients receive surgery. And why is that? Well, a lot of patients are fearful. They're fearful of complications potentially, and sometimes difficult to think about going through a procedure that requires a recovery process, even with the advent of laparoscopy. Now, with the endoscopic procedures that are coming around the corner, there's a lot of potential for less complex, less expensive procedures that may increase the number of patients and even potentially allow us to intervene earlier in their disease. So I'm going to talk about really just two procedures today, and I want to make sure that people understand when we talk about sleeve gastroplasty, we're not talking about the endo sleeve like you see pictured nearby. We're really talking about two procedures tonight, and that's primary obesity surgery, endoluminal, or the pose procedure, and endoscopic sleeve gastroplasty, which is really a procedure that was utilizing the Apollo device, or some people have quoted as the Apollo method, for a greater curvature plication. We're not going to talk about the intragastric balloon. That is another option for primary surgery. That could be a topic all on its own, but I'm going to limit it to just suturing procedures of the stomach. So the pose procedure utilizes equipment that Dr. Chan talked about earlier. This is from USGI. It utilizes an overtube, as you see here in green. I'm going to see if I can get the arrow here. I'm having a little trouble, but this is a completely endoscopic procedure that uses an endoscopic access device, which is that green overtube that you see. Through that, a pediatric endoscope or gastroscope is placed that you see kind of in the far part of the picture. A helical grasper is then used to grab tissue, and then an endoscopic grasper, or G-prox, is used to grasp the tissue and aid in a needle-based catheter going through the tissue. It's a full thickness bite, as you can see in the bottom right corner, and it utilizes permanent sutures. There are anchors that you can see on either end of the suture that are polyester nitinol tissue anchors that are permanent, and follow-up endoscopies have shown that these last for quite a while. This also utilizes a cinching system to really cinch the tissue together very strongly. A typical setup would look something like this. It's a little bit different than your typical endoscopy. The primary operator, typically, rather than standing on the patient's left, will be on the patient's right and a little bit superior to the patient's head. The assistant will be on the patient's right-hand side. It always utilizes general anesthesia just because the overtube is rather large and would be difficult for a patient to tolerate even under sedation. The patient is always supine. There may be a little Trendelenburg. And the procedure starts off with a routine gastroscopy just to make sure that there are no problems within the stomach, such as ulcerations or tumors. Once the stomach has been cleared for surgery, 8 to 10 suture anchors are placed in two rows in the fundus, and then 4 sutures are placed in the distal body. It sounds very specific, but actually this has been studied quite a bit. This procedure has been done several thousand times, mostly in Europe. And over the years, a lot of learning has resulted in knowing that even though you may think that putting more sutures and inverting the stomach more and more would result in more weight loss, that's actually not the case. So we'll go into a little bit why that is, but in the following slides here. One of the first papers to come out was, again, from Spain, Dr. Lopez Nava. They had 2 years worth of patients, about 150. Most of those patients followed up. And this procedure, as you'll see, is kind of a theme throughout when it comes to talking about these endoscopic procedures, are very safe. There were no adverse events at all in these 147 patients. And most everybody was discharged the same day. You can see here on the bottom the graph of the total weight loss as well as the excess weight loss percentage. So on the top you have percentage excess weight loss, which was about 45%. And then on the bottom, about a 16% total body weight loss. Over 90% of the patients had 5% or greater total body weight loss. So this is pretty good procedure and very promising. That led to some further studies, and the next was done out of Miami, and they actually looked at not just what the weight loss is, but also whether or not any of the hormones related to satiety and fullness and hunger were at all affected by this procedure. So 18 patients were looked at with about 15-month follow-up. One patient did not follow up due to pregnancy. The total weight loss was very similar to what we saw earlier, about 19%, and the excess weight loss was 63%, so about the same, maybe a little bit more than what we saw earlier. What they specifically focused on, though, in this study was the intake capacity, gastric emptying, the glucose-insulin ratio, and the hormones related to satiety like ghrelin and PYY. What they found was a very significant decrease in the intake capacity from 901 to 574 kcal. They did find that gastric emptying was delayed at 2 months. The glucose-insulin ratio improved, and there was an enhanced postprandial decrease in ghrelin, as you see to the right. That's the first graph on the right. There was also an enhanced postprandial increase in PYY. Now, this study was partially funded by industry, but it's very promising because it actually looked at the mechanisms and not just the weight loss. So that's the pose procedure. I will say that the randomized trial has been performed throughout the United States. There were about 12, I believe, centers involved. We were one of them. This was a randomized blinded trial with sham controls. So 2/3 of the patients actually got the pose procedure. 1/3 got a bougie through the esophagus for about 20 minutes. And we have 1-year results that are going to be announced and published at DDW, and I unfortunately can't show you those results tonight. But I will tell you that the procedure, this was a highly monitored by the FDA. Procedure was found to be very safe. There were minimal complications, and the weight loss results will be discussed at DDW next month. So another promising method is a greater curvature plication. This is a bit different than the pose procedure. It utilizes a different instrument. The instrument is OverStitch, which you can see in panel B there on the slide. And basically, this device is slightly different in that it cinches, but it is able to grasp more than one place in the stomach and cinch them together. So in essence, it can take bigger bites. The first description of this procedure was by the Mayo group, Chris Castout. And you may have seen this procedure and the results from this procedure at 1 year got quite a bit of headlines within the media. You can see here in the bottom that in panel A how it's done. Basically, a bite is taken in the greater curvature side of the stomach anteriorly. Another bite is then taken out at the greater curvature, and then a third bite taking more medially, and then this is cinched together. So again, so 1 and 3 would come together. And several sutures then are carried out proximally to narrow the stomach, very similar to what a sleeve gastrectomy would look like. You can see again in panel C what the end result typically would look like. Now this is the Mayo technique. There are other techniques out there. There are some, again, Dr. Lopez Nava in Spain, who may take more bites than this. I know Erik Wilson, who is joining us tonight in his discussion on GERD, has maybe a slightly different method. But this is the most described in the literature so far. So Dr. Castout and his group at Mayo then published their 1-year results. They had 25 patients who started the procedure at about a body mass index of 35.5. Procedure took 98 minutes, at least the last 5 patients. It takes a little, there's a learning curve. It took a little while at the beginning, but they were able to get it down, and some now are getting it down around an hour or 55 minutes. Like the pose procedure, is done under general anesthetic, oftentimes in the GI lab, and most patients go home, if not all, the same day. So in the Mayo Group study, they had a median follow-up of almost a year, about 9 months. And you can see the percent excess weight loss here at 6 months was 53%, 9 months 56%, 1 year 54%, and even the few patients out 20 months had about a 45% excess weight loss. Now these numbers are pretty remarkable. As you probably know, these numbers rival the gastric band. So you're talking about a much less invasive procedure that has outcomes that, at least in the short term, are fairly durable, and that's why this procedure has gotten a lot of media attention lately. So you can see here at 20 months, 5 out of 8 patients had 72% excess weight loss. 3 out of 8 patients regained all their weight loss. So again, you know, very similar to bariatric surgery, whether laparoscopic bypass or sleeve. There are some patients who are going to lose weight and gain it back. There'll be some recidivism. But the fact that the majority of these patients have lost weight and done well, though it is a very small sample size and we're very early in the process, this is showing an incredible amount of promise. So out of these patients, most of them were discharged the same day. 8 patients that were admitted for about 1.5 days. There were some serious adverse events. I guess that could be looked at as a good thing. You know, you're actually doing something. You're taking full thickness bites of the stomach, so hopefully that'll result in a more permanent reconfiguration of the stomach. But with that comes complications. One of which was a fluid collection that required percutaneous drainage, pulmonary embolism, pneumoperitoneum, and pneumothorax. You can see to the right there are pictures of some patients that had endoscopy at 3 months. And I think the important part here, and the one thing that has everybody skeptical about the long-term results of these procedures, are whether or not sutures in the stomach are going to hold for the long term. You can see here that there are still some fibrotic bridges at 3 months, and some patients have even had endoscopies out over a year with a very similar appearance. So still very early, but it is showing some promise in terms of more than just a very short-term outcome, but we're getting out to almost 2 years now, and there's still some changes in the stomach that are not being lost over time. So hopefully this will be something that remains permanent and will allow more and more patients access to the procedure. So again, they looked at some other factors that could be involved, such as hormones and gastric emptying. And what they found was a 90-minute increase in the 50% solid emptying time. So the gastric emptying study that was performed at 3 months did show that there was still some delay in gastric emptying, and there's some thought that this may play a role in the weight loss that we see. 32% of the meal was retained compared to just 5% preoperatively or pre-procedure. In terms of hormonal changes, there was significantly increased satiation reported by the patients. There was a 59% decreased caloric intake to reach fullness. There was an earlier termination of the meal, so 11 minutes versus 35 minutes. So patients felt satiated earlier, and they stopped their meal much sooner. There was about a 29% postprandial decrease in ghrelin. There was no significant change in leptin, GLP-1, or PYY levels in their study. There was some improved insulin sensitivity that probably came along with the weight loss. And there was a postprandial glucose and insulin decrease. Now, as I mentioned earlier, Dr. Lopez Nava out in Spain also is performing this procedure and reported 50 patients in obesity surgery last year. The average BMI, similar to the Mayo Group, was around 35 at 37.7, and his procedure duration average was about 66 minutes. On average, their group uses about 68 sutures. In his study group, there were 0 adverse events, and he had 13 patients out at 1 year. The mean total body weight loss was about 19%, which was about 21.6 kilograms lost. His mean percent excess weight loss was 57%, and the mean BMI was 30.9, so a decrease from 37.7 to 30.9 on average. You can see here a contrast study after the procedure that shows kind of a sleeve configuration of the stomach. And then again, to the right, 1 year post-procedure, there are still sutures intact with fibrotic bridges, and so far the sutures have been holding. Now they looked at what are the predictors for success after this procedure, and to no surprise, what they found is that the patients that followed up more often, whether with a surgeon, the dietitian, or psychologist, had more weight loss and they did better. The one kind of fault in this paper was it wasn't clear if technical points were a part of the univariate or multivariate analysis. And so, there's still a lot to be known and gathered about these procedures in terms of how much the technical aspects matter. So in conclusion today, we talked about really two of the best procedures out there right now for primary obesity surgery when it comes to a suturing procedure. Both the pose and the greater curvature plication are definitely safe, and they're effective at least in the short term. We obviously have no long-term data, and I think that a lot needs to be known about this because, as we know, suturing the stomach, may not always last. And so if this procedure, only lasts a year or two, that may, make a difference. Now, this is different than the intragastric balloon, which has to be removed at 6 months. So my prediction would be that the gastric balloon is probably going to lose its popularity once the suturing procedures become more available to patients, because again, you have a procedure that not only is resulting in more weight loss in the gastric balloon, but it seems to be very safe and have a bit longer weight loss outcome. So the randomized controlled data for the pose is imminent. We'll hopefully see that soon. And keep in mind that a lot of these devices are very early generations. Endoscopic technology continues to improve every day, and we're going to see more and more surgical procedures that we can do better and better. And so what we're seeing now is a great start, but I know that in our generation we're going to see much more and better. And I would urge all the residents that are listening or even attending that have not really integrated endoscopy into their practice to really do everything you can to learn endoscopy, to learn more advanced maneuvers in endoscopy, because if you don't, you may be left behind, much like the cardiac surgeons who didn't really learn how to perform stenting. If we don't learn endoscopic procedures as GI surgeons, we're going to wind up losing a lot of cases. There are already cases out there such as what Dr. Davis mentioned, POEM for achalasia. If you don't learn POEM, it's going to be unlikely that you're doing a Heller myotomy laparoscopically in the future. You don't learn endoscopic ablation of Barrett's esophagus, you're certainly not going to be doing esophagectomies for high-grade dysplasia in the future. And so I would urge you to do everything you can. Bariatrics may be the next frontier. Who knows, if these procedures work well, gastric bypass or sleeve may at least become less common. I doubt they'll ever go away, but they may become less common. So again, I urge you to learn endoscopy. Thank you very much.
Great talk, Michael. I want to really compliment you on being on the cutting edge of innovation. One of the first things, going back to your focus on having the residents really learn endoscopy, what would you advise graduating chief residents on the skill set they would need to have in order to do this procedure? In other words, what procedures would they need to be comfortable with in order to progress with learning this technique?
Well, it's like anything else in surgery. I mean, it's progressive. I think that, first of all, I got to learn the basics and the fundamentals. And once you have those down, stepwise fashion learning more advanced techniques like stenting, obviously, suturing with these instruments is not difficult, I believe, for a surgeon to learn. The OverStitch that's used for the greater curvature gastroplasty is actually very similar to a laparoscopic endostitch. And if you know how to use an endostitch laparoscopically, you should be able to figure out how to use the suturing device as well. But like anything else, it just takes practice. But having these tools is extremely valuable. The OverStitch for the gastroplasty is being used for multiple different procedures like stent fixation, closing perforations, fistulas, and so forth. So it's a great device to have and a great device to know how to use. And I think very easy for surgeons to figure out. Our gastroenterologists that help us train our residents will tell us that the surgery residents pick up endoscopy very fast. So.
The second question I have, you mentioned the durability of the device and whether or not the durability of plications will continue long term. Can you comment on, going back to Dr. Chan's talk, about the possibility of repeatability or the ability to do this multiple times over a patient's treatment course?
Yeah, I mean, that's a great question. I think that, you know, one of the FDA's hang-ups on some of these procedures was not just repeatability, but actually if we do this procedure and it fails, is the patient going to burn a bridge? Are they going to be able to have a gastric bypass or a sleeve gastrectomy? And, you know, I know that we presented at SAGES a couple of years ago, and some others have found that it really isn't a problem. It doesn't burn a bridge. And sutures can be removed endoscopically. So again, back to your first question, another good skill to learn is just endoscopic cutting. But sutures can be removed if they have to be, oftentimes either externally or internally. These procedures work because they're full thickness bites. And so oftentimes you can see the sutures on the outside and you can cut them free that way as well. So I think that there's certainly no problem doing these procedures again. I know that for some of the revisional procedures, you know, I've had a couple patients who I've had to redo, and it was not a problem. The sutures are there, you can see them, but they can be removed. And so I would assume it's going to be very similar for the primary surgeon as well.
In introducing new technology, you're always, you know, facing, you know, high hurdles. What I'm a little bit interested in comparison to the transoral gastroplasty, which was the staple technique that had some very critical early patient deaths from gastric perforation, do you feel like there's any risk of introducing this new technology with that risk of transmural suturing that you're discussing?
Yeah, well, these devices have been around for now a long time, but there's always that risk for sure. But fortunately now, I mean, thousands of these have been done, maybe not in this country, but out in Europe, for example, and in South America, and that has not been a problem. There is an occasional perforation, but it's well under 1%. It's definitely something that you have to advise the patient as a possible risk, but it's a very low chance.
How would you manage those perforations in, you know, the sense of whether you use stents or other adjunctive endoscopic technologies?
Yeah, well, that's a good question. I mean, I think that, you know, a gastric perforation obviously is going to be hard to stent, but an esophageal perforation you could. Some perforations, if you recognize them at the time of the procedure, could be just managed with the suturing device. We actually have used this device to close perforations that have occurred during screening colonoscopies and upper endoscopies, and it works very well. If, however, it's difficult to close endoscopically, there's always the option to laparoscopically intervene and close it from the outside or staple it off, for example. I think another advantage having surgeons, you know, doing these procedures is that we have those tools in our toolbox. We can intervene both laparoscopically as well as endoscopically. I realize now too, Brian, by the way, that I had two videos that were part of the presentation that I think had to be separated out, and I don't know if it's too late, but there's two videos that really kind of show well the pose procedure. So if you're interested, we can try to bring those up. I don't know if that's possible or not, if Steve can do it.
We can. What I'm going to mention is, Dr. Wilson, I've got one question for you, and I think during the discussion we've got approximately 20 minutes, which is a great time to bring up, you know, further interest and show the videos as well. One of my residents is definitely asking for the videos. There's an Amr REA who wants to know when you're going to start teaching this so we can travel and see you to learn it. We look to approve.
Yeah, well, I think that you know, the data that's coming out next month is going to be very helpful in terms of you know, starting to spread the word, and you know, there are courses that are available, and we'll make sure that she's invited.
Great, great. Well, fantastic. I think we should show the videos probably. How long are your videos, Michael?
No, they're very quick. They're less than a minute. There's 2 of them only.
Go ahead and, I think we should go ahead and show those videos. There's quite a demand from the residents to see those videos currently, so I think it's a good idea. I think Stephen can show those for us.
So, Steve, can you go to the first video there? Yeah, there it is. So here we are. So we're in the stomach. We're retroflex. You can kind of see the green overtube at the 12 o'clock in the picture. We have the tissue helix that is grasping the tissue, and you can see there's the needle. That's a hollow needle going through the tissue. It's a full thickness bite. The suture and anchor then is propelled out of the needle. And this is, again, the pose procedure. This is the first procedure I mentioned. So we then, that's what it looks like when we're done. And, you know, we'll then put a second row right next to it. As you can see here now, we've put 2 rows in place in the fundus, and then we'll put a third row down in the antrum. And there's the row on the antrum. Now, it doesn't look impressive. I remember doing this procedure and for the first time and saying, boy, it doesn't look like I'm really doing that much, you know, grasping this tissue. And then the next video, I think, which is an ex vivo video, really shows what you're doing. So again, there's a tissue anchor being pulled out, and then we'll just cinch it. So the camera that I had. Model, and we're going to do the exact same thing. This is a porcine stomach. You can see we're looking at the fundus. The tissue helix now is grasping the tissue there. Once the tissue is grasped, we're going to pull the tissue towards us and desufflate. You can kind of see the shadow of the instrument now coming in. We're inverting the fundus now, and then if you watch carefully, you'll see the needle come out. It's a full thickness bite. But you can see it looks a little bit more impressive on the outside than it does on the inside in terms of how much the stomach actually is inverted. So right now the needle is going to come out right there. It's a full thickness bite, so you get serosa to serosa. We think theoretically this makes a difference. We know mucosa to mucosa will not have any long-term effect, but we hope that serosa to serosa may.
Well, I think that serosa to serosa is critical, and as we're seeing in the discussion between Dr. Ponsky and Dr. Chan, they bring up an excellent question of whether you've considered ablating the mucosa prior to firing these devices to allow for more scar formation, a better approximation of those tissues.
Yeah, and I think Dr. Ponsky brings up a great point. I mean, we definitely do that during the revisions. You know, most people don't do that during the primary procedures. It might be something to look at. You can see here we have a permanent full thickness suture there that has been deployed, and then we're going to cinch it down. And, you know, that's just one stitch. So you can imagine if we do 2 rows of 4 to 5 stitches each, we invert the stomach pretty well there. So hopefully you get a little better idea of what it looks like both in and out. And I apologize that those videos didn't come up during the presentation.
Well, they're fantastic videos, and I'm very happy to say we have the time to have a very robust discussion about your technique. I'd like to, if you're complete, Michael, and it's good timing, I think it's a good time to introduce Dr. Erik Wilson. Dr. Wilson, Professor of Surgery, Vice Chairman for Clinical Affairs, and Director of the Minimally Invasive Surgeons of Texas, graduated from Texas A&M as an Aggie and a fellow Baylor graduate, completed training at Scott & White, and is currently, again, faculty at UT Houston. Welcome, Erik.
Thanks, Brian. How are y'all? Y'all doing well?
Great.
All right. Okay, so we'll get started. I'm supposed to talk about endoluminal reflux. I think, Mike, you did a great job on talking about primary procedures. I don't know if we mentioned, I think one of the things around endoluminal reflux treatment, a lot of these endoluminal procedures is to stress the need of CO2 insufflation. I think CO2 insufflation is really important to help prevent, because these are full thickness procedures that we're doing. You're going through the wall, and these are the early successful procedures around utilizing notes, basically notes devices, and these endoluminal devices, which aren't necessarily always going through an organ to work on another organ, but actually working on an organ. You're making full thickness holes, and we need to use CO2 insufflation routinely in these situations. That definitely applies to the gastroplasty, and I think that's one of the reasons that perforation complications are really low. When we're technically perforating these people when we do these operations, but the body handles it really well because we're not putting a lot of nitrogen across, we're just putting CO2. If you watch these patients and evaluate these patients, whether it's bariatric or reflux, and look at them immediately post-op, you'll see free air, and you want that free air to be CO2. So I think it's really important to stress that CO2 insufflation should be kind of a standard mechanism for dealing with all of these endoluminal therapies that are aggressive. So I'm going to talk about endoluminal reflux a little bit. Dr. Ponsky is going to talk about, these are my disclosures. Dr. Ponsky is going to talk about strata. I have it in here a little bit, but I'm not going to hit it very much. I'm just going to gloss over it because I know Dr. Ponsky is going to spend a lot of time talking about it. So I'll talk about the other endoluminal options. You know, if you look at esophageal cancer, a lot of y'all have seen this. This is the fastest growing cancer in the United States. It's not the fastest by prevalence. It's definitely not the most prevalent cancer, but we haven't done a good job of managing this disease. It's gotten worse and worse as reflux has gotten worse, and it's also gotten worse in spite of the standard mechanistic treatment of PPI use. And so we're not fixing this problem with pharmacotherapy at this point in time. Although pharmacotherapy does work pretty well to control the symptoms, and it's interesting that the drug companies have called it acid reflux. Well, it's gastroesophageal reflux disease. It's not just about acid. It's about refluxate coming up into the esophagus, and that may not always be acid. And I think it's important for us to differentiate that to our patients when we're talking to them. So I've started managing our reflux patients in a chronic disease model, much like the obesity patients, where we come in and we offer them a whole host of treatment from medical to surgery, and we just give the advantages and disadvantages of each of them. And if you address your patient population in that perspective and offer a whole continuum of treatment, and also offer it in the mechanism that this is a chronic disease, we're managing this disease, we're not curing or fixing your reflux permanently. If we argue from that perspective, I think the patients are more willing to stick with us, and we're willing to follow with us long term. So if they do happen to have any recurrent reflux, they don't go somewhere else. They continue to see us, and we continue to manage them. Because even surgery, which does the best job of controlling reflux, if the patient has some recurrent reflux and you've said, I've cured your reflux when you do their operation, then when they have recurrent reflux, they don't come back and see you. They feel like, well, he said it was cured. Why would I ever have reflux again? Now I do. And they may just need some mild adjustments in either their procedure, and we can tune these things up endoluminally now, or surgically, or continue to follow them and adjust them from there. So I think it's important to look at it this way. If you look at the number of over-the-counter prescriptions for PPI use, it's 134 million, and 19 million Americans take PPIs daily. That's a lot of people. But people are still unhappy. 10.2 million visit a doctor for reflux, and there's 6.7 million EGD exams, upper GI, upper endoscopy exams done a year in the United States. And then we have all these safety concerns that are escalating over PPI usage. And some of that's a little overblown, I would say. But you absorb less effectively when you don't have acid in your stomach, and there's some real side effects to that. And these drugs have not been studied in the realm of what is it like to take these drugs for decades. And that's what these patients are doing now. And they have some malabsorption issues because they don't have acid in their stomach anymore. And so I encourage patients to take holidays from PPIs periodically to normalize their acid. We don't really know what's an effective holiday, though. We still need to do more research on that. But we know that they don't absorb as calcium as well. They don't absorb as magnesium as well. There's certain amino acid deficiencies. There's been associations of hypothyroidism because you don't absorb tyrosine as well. Tyrosine is a precursor to the thyroid hormones. So there's multiple deficiencies that are now being found because of chronic PPI use. And they are a safe drug, and we do know that, but they do have some side effects, and I think it's important to make sure patients understand that. I think patients are paying a lot of attention. This is interesting. If you look at January 11th, this is basically hits online as it relates to a JAMA internal medicine article that linked long-term PPI use to chronic kidney disease. So there is a lot of attention out there around the use of PPIs. And so I think that's important for us to make sure that we're having a balanced conversation around what the advantages and disadvantages of PPI use are. So let me look a little bit about the historical endoluminal treatments, and there were basically 3 of them historically, but one is held on, and that's the Strata, and Dr. Ponsky is going to talk about that. But the Endocinch, which was talked about with gastric plication, that was the original gastric plication procedure, was done with Endocinch. It's no longer on the market, but it was made by Bard, and was basically a mucosally based suturing device that would bolster up the valve at the EG junction. Had a little bit of effect, but it was more mucosally based. You could oppose tissue together with it, and the early studies looked okay with some good satisfaction, but no longer on the market. The Endioplicator was another one, and if you selected your patients well, it actually helped a decent amount. And this is more similar to what you see with the devices now, basically using a helical retractor to grab the lower esophageal sphincter or the Z-line at the EG junction and retract it and pull it down and then create a plication to try to more mimic a fundoplication, what is often called now a fundoplasty. And so this was a pretty good device, but also came in a little bit early and was hard to get on the market in a way where it could make enough money to survive. So this IP got sold off, and I think it sits on the shelf at Ethicon now, or J&J. And this is the Strata. So if you look at Strata, it's been around for quite a while, and you got to give the procedure some credit because it's stuck with it. It's gone through a few different companies, but it's made it through with quite a bit of data to support it, and is now coming onto its own again. It's basically radiofrequency ablation. It ablates the lower esophageal sphincter. I'll let Dr. Ponsky talk about it. It's been shown in both in humans and animals to thicken the lower esophageal sphincter. And SAGES and ASGE have provided statements that are supportive of it. And these ASGE guidelines and SAGES guidelines basically say endoscopic therapy is now coming into its own and should be considered. And SAGES particularly has been most strongly supportive of Strata up to this point in time as an endoluminal therapy because it had the most level 1 data around it at the beginning. But now some of these other procedures are starting to have more data supporting them, and that's what I'm going to show. So SAGES gave its strongest grade recommendation around the Strata. It has lots of long-term data as well, up to 10-year data, which I think Dr. Ponsky will talk about. And here's a meta-analysis showing that it works. So one of the things that I think is interesting around Strata is it would be the one procedure that I'll show tonight that you could actually use in bariatric patients who've had sleeve gastrectomy because it's a low enough profile where you could still do the procedure. And so this is a registry study after Dr. Sama Murtar did a study showing it improved some symptoms in patients who had had reflux and sleeve. One of the common arguments and discussions around sleeve gastrectomy is that it potentially has a population that gets reflux after sleeve gastrectomy, and so this may be a way to manage that endoluminally. So there's actually a registry trial that's starting right now to look at the use of Strata for this. You couldn't do these other procedures such as Muse or TIF because of the size of the device. It just wouldn't allow you to do it in a sleeve, but a Strata is actually a good option in that. So we'll see how that unfolds with time. Let me talk about transoral incisionless fundoplication, or esophax, because that's what the title of the talk was supposed to be about. But there's actually 2 fundoplasty devices out there on the market available. One is called the Esophax, that's the brand name, or transoral incisionless fundoplication by the company Endogastric Solutions. And another one's by a company called Medigus. It's the Muse device, which is transoral stapler to help create a fundoplasty. So fundoplication or fundoplasty, basically folding the fundus onto the esophagus to bolster the lower esophageal sphincter, much like a fundoplication done surgically. Both of these devices are built around that concept. The Esophyx has gone through 3 generations of devices and multiple iterations within each generation. So this is a device that's been on the market for close to 10 years now and has slowly gotten better and better and better. But it's a relatively complicated device. It has an endoscope that goes down the device, and then the device folds on itself, and you use a helical retractor, much like that endioplicator, to grab the Z-line and pull the valve down into the abdomen to reduce any small hiatal hernia. It also has those holes in the gray portion of the tissue to grab the esophagus, to push the esophagus down and reduce any small hiatal hernia. And then it's got a clamping mechanism or a hand, so to speak, that will grab the stomach. So you have 3-point fixation to grab the lower esophageal sphincter, the stomach, and the esophagus, fix them together, and then it uses these fasteners, which are basically Prolene sutures. So it's a sutured fundoplasty or fundoplication to bolster the stomach to the esophagus, usually between 1 and 3 centimeters above the Z-line. So you actually are suturing from the stomach and from the esophagus to the stomach. So these are holes that you make with these fasteners through the esophagus into the stomach, small perforations that are held with these sutures. And believe it or not, these actually work very well in supporting the fundoplication. You do somewhere between 20 and up to 30 of these sutures to create the fundoplasty, and that's how it works. And this is the latest generation device, which has gotten a lot more user-friendly as it relates to firing the sutures. The suture, there was lots of technical skill around how you deployed the suture to make sure the suture ended up in the proper place, but they've improved the device to the point where it's become a lot easier to fire it. Most of the people that do this procedure are surgeons, actually, but more gastroenterologists are getting into it. But because it's a relatively complicated procedure, surgeons were more attracted to it than the gastroenterologists. And if you look at the percentage of procedures that are done, well over 80% are still being done by surgeons. But that will change with time. And I think what Mike was saying about making sure we keep our skill set going around flexible endoscopy and these types of procedures can't be iterated enough, because gastroenterologists are learning how to manage reflux patients with procedures now. So let me talk about a little bit of the level 1 data around this, because that was one of the biggest complaints about it, is there was no level 1 data when it came out and it was put on the market. But now there is. There's 2 studies. One's called the RESPECT study, and this was a randomized, multi-center, double-blind, controlled level 1 comparative study. So the patients were sham controlled. So they basically got two groups of patients. The treatment group got the procedure, and then they took a pill that was a placebo, so they didn't actually take a PPI. And then the control group were put to sleep. They had the device placed. Actually, they didn't have the device. They had a bougie placed down and left in place for 30 minutes, about the length of the procedure. And then they were woken up. So they were put asleep for a similar period of time as the procedure. They were woken up, and then they were put on a pill, but actually were given PPI. So we're comparing patients who were blinded and do not know a treatment with a TIF and no PPI versus PPI. And we'll look at the results here. So basically what you saw as a primary endpoint, we were trying to look at resolution of troublesome regurgitation, not just pure heartburn, but actual regurgitative symptoms, which means the patients had more severe reflux to begin with. Because if a patient has regurgitation, usually the reflux is generally more severe than just typical heartburn. And if you compare the responses, the patients who got the actual procedure had a better resolution of troublesome regurgitation than the patients who were on PPIs and got the sham procedure. If you look at acid exposure, he had significant improved acid exposure at 6 months on the patients that got the procedure versus the sham control group. And if you look at it at 12 months, the heartburn scores and Demeester scores significantly improved compared to pre-TIF. And you'll see a trend here where Demeester scores on these types of procedures tend to not completely normalize. They tend to not get below 14 or 15. They tend to stay at this level around the 20s. That's a pretty common number. These patients had pretty significant reflux if you see that Demeester score of 33.6 pre-tip. So these patients have real reflux. They're not mild symptom patients, but they have to have a hiatal hernia of 2 centimeters or less. And you measure that based upon diaphragmatic width and axial displacement. Also a slide about that in a second. But because of that, because of the significance of their reflux, these procedures are not as aggressive as surgery, and so your mean Demeester scores tend to not normalize as much as you get with surgery. But like I said, patients will come in, and this is all they'll want. They'll want an endoscopic procedure, and they just won't want a Nissen. And so we offer all the patients that come in, we offer them all the options, and if they qualify for an endoluminal procedure, we'll let them have that, understanding that it may not resolve their reflux as aggressively as surgery, but that may be all they want. Here's data around quality of life, significant improvement in quality of life. And when the patients that had the sham arm were offered the crossover at 6 months, they could then be treated. Their quality of life significantly improved as well. So the crossover study improved as well. So basically what we're seeing is that transoral fundoplication is better for quality of life, and GERD scores are significantly improved and maintained up to 12 months. And we need to continue to follow this cohort of patients, which we are doing. These patients are continuing to be followed to see how they do longer term. The next study is called the TEMPO study, and it's a study of comparison of 2 groups as well, but it was open label, so the patients knew whether they got it or not, but it was treatment group versus PPIs, and looking at 6-month and 12-month data and a 6-month crossover. If you look at elimination of troublesome regurgitation, you had a significant improvement in that over at both 6 months and 12 months. Atypical symptoms are actually significantly improved as well, and atypical symptoms are one of the things that I really like for these procedures, because when you do surgery on them, sometimes the atypical symptoms are harder to resolve with surgery, and the patients can, if they have atypical symptoms and you do an endoluminal procedure, you haven't burned a lot of bridges, and actually they do have quite a bit of improvement of atypical symptoms such as upper respiratory and those types of symptoms. Significant improvement of regurgitation. I'm going to speed up on this. 9 of the patients had troublesome regurgitation on high-dose PPIs, and 2/3 of those actually reported no regurgitation after the tip. So on the crossover, it actually shows that it helps eliminate regurgitation. And this is the atypical symptoms comparing, using the PPIs versus the tip. Significant difference there, 62% versus 5%. They now have 3-year data on the TEMPO data, and 70% of patients are off daily PPIs, so not everybody's off of them, but significant improvement in GERD HQRL scores, elimination of troublesome regurgitation, a reduction in reflux episodes, esophagitis healed in 86%. So basically what you're seeing here is these procedures work. They're not as powerful as surgery, but they work, and something we should offer. And there's the durability as it relates to a registry trial that we did, looking at how long this lasts. And I think it seems to be fairly durable, because there's a significant number of studies now looking at 3 years and 4 years out. But it may not last forever, but that may be enough for people who do not want surgery at this point in time as a endoluminal procedure. And if you look at the safety profile of these procedures, they're actually very, very good, with extremely low mediastinal abscess rates, extremely low bleeding rates requiring transfusions. It's just an extremely rare thing. It's not unheard of, but it's in the 1 in 1,000s kind of risk. So it's a pretty safe procedure. So there's more studies ongoing with this device, but I think it has now shown that it's got good level 1 data to support it. We talk a little bit about the Medigas stapler, because this is another one that is out there. It's actually FDA approved and is on the market, but is only being rolled out in a registry at this point in time. So if you ask to start doing the Muse, if you don't participate in the registry at this point in time, you're probably not going to get access to the device. It's actually a disposable device. It doesn't look like it's a disposable device because it has a camera and a stapler, but it is. It has a monitor and a control console, and is both FDA approved and CE marked. It basically goes down, and using a stapler and an ultrasound through an over tube, you bring the end of this scope onto a stapler housing, align it, fire some pins across to align it further, clamp the tissue, and then you fire staples. And these staples are usually a row of 5 staples, and you can see the configuration in this picture of 5 staples, and usually do 3 to 4 firings of this, sometimes 2, but most commonly 3, and sometimes 4 firings of this to basically do a fundoplasty or fundoplication. So another example of creating a partial wrap transorally. This is kind of how it looks pre-procedure and post-procedure, first, second, and third stapling. The studies were first a pilot study and then a pivotal study, which basically looked at, was the trial that got FDA approval, showed a 73% of patients with a drop in 50% reduction of health-related quality of life, and the pivotal study was carried out to 4 years. So very similar. If you look at the data as around this early data and compare it to some of the TIF data that's out there, you get very similar results. There's no sham-controlled data as it relates to this, and I think that's something that will be coming down the line. But the first goal of this company, it's a relatively small company, is to get enough successful patients out there from a registry trial where they could do further study. Here's basically the registry enrollment. So there's about 44 patients in this registry, and that's how it's being rolled out right now. And we're very curious because we're participating in this registry and we've been doing TIF for a while. You know, is there certain advantages or patient populations where one is going to be better than the other? And we just don't know that yet. I think there's going to be a lot more study being done on that. So there's a new CPT code for fundoplasty that both the gastroenterologists and SAGES allowed and worked for to get, and this took a lot of work to get there, but we now have a CPT code on the books. And I want to show you how it kind of compares to the surgical procedures, because a lot of people out there, and especially some of the surgeons out there who do fundoplication regularly, are like, well, this just doesn't make a lot of sense from a financial standpoint. And if you look at the work RVUs, which in the adjusted or approximated reimbursement around this, you can create a dollars per minute estimate. And these are estimates because procedure times can certainly vary depending upon the procedure you're doing. That being said, endoscopic fundoplasty gets a work RVU value of about 7.75, where if you get like a lap Nissen, it's about 18 RVUs. A paraesophageal without mesh is 26, and with mesh is a 30 RVU. So it's only 7, so it's about a little bit less than a third, or a little bit more than a third of a Nissen. And the strata is also 4.25 RVUs. They're working to bring that up to maybe 9 RVUs for the endoscopic fundoplasty. That being said, for the amount of time it takes, your reimbursement may not be as good, but it's still reasonable, and you can make it work. And the one difference is, if you look over at the far right, the global period, you can actually charge the patients for the follow-up, which you can't do with surgery. So that's one of the ways to offset the cost. And surgeons who look at these procedures, they may not admit it, but they do look at how much they get reimbursed for this, and I think that plays into this. But you can get reimbursed for follow-up care immediately, and I think that's an important factor to consider as it relates to these things. So the other things that are out there as it relates to reflux that aren't endoscopic, just so you know, there is electrical stimulation around the LES. That has been done. There's some early studies that show it seems to have some value. This being done endoscopically might be very valuable. We need to keep our eyes open to see how this progresses. And then magnetic valve sphincteroplasty is the other one. That's laparoscopically placed, a magnetic augmentation of the valve. It actually has some pretty decent data around it and more studies being done around it, and they're working on getting a code and reimbursement. And then one of the interesting things, this is the OverStitch device on the left and the TIF device on the right, and you can actually use the OverStitch to do fundoplasty under retroflexion. It's not easy to do, but I've done several patients this way, and it's really kind of the first pass at using multiple tools to create an endoluminal fundoplication, where I used the OverStitch and then I did a tip on top of the OverStitch on a patient that had a slightly higher hiatal hernia, trying to and still didn't want something laparoscopic. It's very interesting, as I've been doing this over the last many years, my laparoscopic fundoplication growth has not gone down at all. If anything, it's gone up. So I don't think people need to feel like if they start doing this endoscopic procedures, they're all of a sudden going to kill their Nissen business. If anything, they're going to continue to have more of it because they're going to have more patients flowing through the doors that want to have reflux treatment. And then I think ultimately NOTES procedures and endoluminal robotic platforms will be on the horizon. Of course, me being a robotic surgeon, I had to say something about that. I think it's important to get back to a little bit about what Mike said about endoscopy. We do a lot of upper endoscopy. We need to get much better about consistently grading hiatuses. Gastroenterologists don't do a great job with this. We work on hiatuses. We need to make sure we get very descriptive about how we describe a hiatus. And I think it's very important to know that when you're doing these endoluminal procedures, but it becomes very valuable in general when you're following patients long term if you know how to describe them. And there's really three variables that I recommend people describe. One is axial displacement, which is basically from the diaphragmatic pinch to the EG junction, how far the Z line moves up into the chest. That needs to be measured in its greatest distance. Diaphragmatic width, which is often done on retroflexion, the greatest transverse dimension of the hiatus as you look at the patient. And then hill grading. Everyone should know how to do hill grading, basically how the valve gaps off the scope, whether it gaps not at all, intermittently, doesn't ever close, or you have a significant amount of stomach up into the chest. So we need to be more consistent every time we do an EGD to grade these valves, and I think we should continue to do that.
There's just a better example of where surgeons need to do their own endoscopy and really have
Absolutely.
to take over this field. Forgive me, Eric.
Absolutely.
We have two questions on dysphagia and on revision to room-wide gastric bypass, other kinds of revision. Forgive me because I think we'll need to hold this for an end discussion with the group because I do need to introduce Dr. Ponsky. Dr. Ponsky needs no introduction as one of the founding members of SAGES and the inventor of the per-endoscopic gastrostomy, and has served as chairman of the Case Western Reserve University surgery program. And as I have heard said before, we see farther by standing on the shoulders of giants, and Dr. Ponsky has really mentored many of the leaders in surgical endoscopy to date. Thank you, Dr. Ponsky, for speaking.
Thank you very much. So it's a pleasure to talk a little bit about Stretta, and I think that Eric has covered it a little bit already. So I'm going to go over it and try to describe it to you as I see it, rather than a lot of data. So let's look at it a little bit. Stretta is not new. It's been around for a long time. And it was originally a company called Curon, developed by a surgeon, an ENT surgeon named David Utley from Stanford, who I'll mention again. He was a brilliant guy who's developed not only this, but also the Bariatrics device for Barrett's esophagus. Again, use of radiofrequency ablation. So again, the Stretta procedure uses endoluminal application of radiofrequency energy to treat the EG junction and thicken it in some way. That was the original thought, in order to reduce reflux. So let's go over this a little bit. What is radiofrequency energy? Radiofrequency energy is part of the light spectrum, but it's way to the left of infrared. And so you can see that it is in an area that we're not really used to, but it creates heat. And so radiofrequency electrosurgery is then delivered to the tissue, resulting in movement of water molecules producing heat. That's at least how it works, and so now you've been told. That's all I understand. Now, when you use the Stretta device, there are several things we look at, and I'm going to point this out when I show the device. You want to know the tissue that's generated in the muscle. You also want to know the temperature of the needles where they enter the mucosa, because it causes a burn. And so if you look at this picture of the original device, and it's modified a little bit now, there were two curves.
the curve that had the high temperature was inside the muscle, and that's where you wanted to be. And then the curve with the low temperature was at the mucosal surface, and that was irrigated by ice water, ice saline, so that the needles at the mucosa did not cause a significant burn. So it's a very well-engineered device, and if the temperature ever got too hot at the mucosa, that one needle was shut off. And here you can see a picture of the tissue, and the tissue shows that the surface epithelium is intact, but down low there's denaturing and acute lesion of the muscle, and that's just what we wanted to create. So here you see that originally we believed that this worked by denaturing the collagen in the muscle layer and causing it to thicken, creating a barrier to reflux. And this was the pretense upon which we originally did stretta. And so radiofrequency energy is not new. Dr. Utley knew this. It was used since the 1920s, again, to denature collagen by heat, and it was used to ablate nerves, and then it was used in the joints and in the sinuses as well, and that's how Dr. Utley was aware of it. For GERD, animal studies began at Stanford in 1998 in a pig model, and they tested it by, after they did it, to push on the ex vivo stomach and see if they increase the yield pressure. That means the amount of pressure given to the stomach that made it reflux. It also reversed the effects of Botox after 9 weeks, so it seemed to be effective in vivo. And another thing that it seemed to do, and I'll talk about it later, is it destroyed vagal fibers, afferent fibers, which were in the esophageal wall. These fibers cause intermittent relaxation of the LES and therefore reflux with lowering of LES pressure. It's thought that maybe a major way that the stretta works is by destroying these vagal fibers and preventing the LES from relaxing by transient relaxation, therefore increasing LES pressure. So the stretta procedure is an outpatient procedure. It's so easy, the worst thing you have to prevent is you falling asleep while you do it. It's a very easy procedure. It's often done in the endoscopy suite, and I'll say as I go on that it's often done with like Versed and fentanyl or Demerol, but more people are using propofol now to give an even longer anesthesia. The catheter is placed at the area of the GE junction, and it's the needles are made to go out, and then after a 1-minute application, the needles are withdrawn. The device is rotated 45 degrees. The needles are put out again. This is done by inflating the balloon, and another application is done. This is done in 4 applications going antegrade, and then the device is deflated. I'll show you in a minute. It's inflated in the stomach, and in the stomach it's inflated at 2 levels, so that you have a total of 6 levels of application. It takes about an hour, and the complications are very few. So this is the catheter. It's a very simple catheter. The handle has only one control that goes forward, middle, and back. The forward implants the needle, the middle is where you apply the energy, and back withdraws the needle. It's very flexible, and with the needles withdrawn, it causes no problem. This was the control module. It's been improved with time, but the control module is marvelous because the control module prevents you from applying too much heat. If a needle is applying too much heat or isn't in the right place, it is shut off, and it's a very, very safe and well-engineered device. So here you see the area of the EG junction, and then the catheter with its balloon is placed there. We start at 1 centimeter above the EG junction. Let's say it's 39 centimeters. We then blow up the balloon, and we put out the needles, and we apply them in this position. This is a centimeter above the Z-line. We apply it for 1 application, which is a minute. We then withdraw the needles, and we deflate the balloon. We pull it back and then push it back into the same level, but at 45-degree angle, and do another application. So then we do the same thing at half-centimeter intervals going downward for 4 applications. After we've done those 4 applications, we then put the catheter into the stomach, and we blow it up with 25 cc's of air and apply it at straight, then at 45 degrees in one direction and 45 degrees in the other direction. We then deflate the balloon again, and we put 23 cc's in the balloon and do a second application. So now we have 6 levels that have been treated. Again, the worst problem you have here is boredom, but it's a very easy, safe, and uneventful procedure. Then you are done. You often go into the stomach and look at what you've done. Now, we like to think that it creates thickening of the muscle right away. It really doesn't, but the mucosa gets thickened right away, and I'll show you that. This has been checked in many studies. This is one of the first ones which Utley was involved in. You see some wonderful people in this study, and what this looked at was their heartburn score, whether it was safe, and esophageal acid exposure. And basically, they looked at patients who were over 18 years old who had very minimal hiatal hernias. It had to be less than a 2-centimeter hiatal hernia. They had to have normal peristalsis and a normal LES. And as we went along, we examined these patients at intervals for up to a year, and there were 118 patients, as you can see, of normal body habitus, and their median drug requirement was about 2 tablets of omeprazole a day. And you can see that this was done in an outpatient endoscopy unit with conscious sedation, as I've described, and the mean time was about 53 minutes. And they all essentially tolerated this procedure very well. And the complications were very minor, with some chest discomfort, which required minor analgesia, and the patients went home within a couple hours. The complications were mucosal injury and fever in most cases. But when you talk to these patients, their symptom scores were dramatically increased over the period of a year. Their heartburn scores were reduced. Again, we know we've seen this with every device that's been done, including the EndoCinch. So every time you ask the patient about subjective scores, they're all happy. They all use less medicine, and there's a big placebo effect. So how good could this be? Again, their quality of life is improved. But when we looked at esophageal acid exposure with pH testing, you now see the first objective evidence that it's making a difference, because it halved their esophageal acid exposure, and we know that we say that a pH less than 4% of the time is what we shoot for. We didn't get quite to that, but we got to 4.8 from 11.7. This was quite significant and thought to be a very good sign that it was effective. And their medicine use decreased. So it was concluded that this was an effective method of treating reflux, an endoscopic method, and it was probably by TAM study here shown to be most effective because it reduced transient lower esophageal sphincter relaxation. The O stands for esophagus. It's not American English. But you can see that it reduced transient lower esophageal sphincter relaxations. It increased the basal LES pressure, and it eliminated the need for medication. So this was thought to be very effective. So now, again, this is TAM study showing relaxation is decreased. And again, the basal LES went up, some more data. And reflux was decreased. And transient relaxations were decreased. This is all of what I've said. Now, here you have a picture of, on the top, you see the LES, a retroflex view before a Nissen, and on the right, you see what a Nissen looks like. On the bottom, on the left, you see the patulous EG junction retroflex before ostreta and right after ostreta. Again, most of this is due to edema, and I don't really think this is true thickening, but this is what it looks like, and you can see that there are very minor mucosal burns at the area where the needles went in. These are insignificant. And again, we talked about how this worked by reducing transient lower esophageal relaxation. This next study was a randomized double-blind sham-controlled crossover study, and is multi-center. And Rich Rothstein was instrumental, and Steve Edmundowitz was involved in this as well. So this is a great study because what it showed is if you did the stretta, half the patients got the catheter put in and nothing was done. The other half of the patients had the catheter put in and the procedure was performed, but the patients never knew what they got. And so when you looked at them at 6 months, the patients who got the stretta, who actually got it, had decreased GERD scores. You can see that at 6 months. The patients who had the sham did not have decreased GERD scores very much. But then you can see that at 12 months, the patients who got the stretta had significantly reduced GERD scores. However, if we cross them over, which they were done at 6 months, you see that the sham patients, now that they were treated, had markedly reduced GERD scores. Very impressive. Same happened with the heartburn scores after they were crossed over. Here again now, the objective evidence with the 24-hour ambulatory pH, you see that the patients who had the sham had no change in their pH at 6 months, but when they were crossed over at 6 months, they had a marked diminishment in their ambulatory pH, their acid exposure, and this clearly showed that stretta was effective. And the patient satisfaction, again, was tremendous, and so the conclusion was that this improved quality of life by decreasing the lower esophageal sphincter relaxation. So this was a very important study. So when you choose a patient for this RF, it's important to choose the right patients. I really believe if the patient has tremendous regurgitation, you're choosing the wrong patient. If they have a large hiatal hernia, it's the wrong patient. If the patient is intolerant of PPI, I don't know that it's the correct patient as well. But patients who have mild to moderate or even early severe GERD might be patients who would benefit. It is not for late or complicated disease, and I will say that patients who have had Nissens, for example, and then years later develop recurrent symptoms seem, in my experience, to respond very well to stretta. I also think we're starting to see good uses for it, as was mentioned by Erik before, in patients who have had sleeve gastrectomy and nothing else can be done. I think this may be something to do before you go to a Roux-en-Y gastric bypass. So stick with it. The company is now Mediri Medical, and this is a good therapy. And so I think I'll end there and say thank you very much.
Thank you, Dr. Ponsky. That was an excellent presentation. I think now is a good time to spend the final 15 minutes going to a full panel discussion. One of the interesting questions that was brought up was how do some of these endoluminal procedures affect reoperative therapy? Especially, I know somebody asked whether or not the stretta precluded going forward with a gastric bypass, made it more difficult, or it had any other effect. I know there are some articles out about revision of transoral fundoplication to formal fundoplication. I was wondering if we could have some comments on that as well from the experts.
Well, I just say that stretta has no effect on anything. Stretta won't bother you one way or the other. So you can do a revision, you can do a bypass, and stretta really is hard to notice an effect on. Now, I haven't done a poem on somebody who's had a stretta, so I can't tell you if it's affecting the intramural portion of the esophagus, but I have done Nissens on patients who have had stretta and noticed no problem.
As it relates to the other procedures, the TIF and the Muse, we don't know about the Muse, but we've certainly done quite a few prior patients who've had TIFs, and then their hiatal hernia has gotten significantly bigger, their diaphragm's grown over the years, and then we go into a Nissen, and those patients have actually done very well. The fundoplasty, you leave it alone, and then you bolster it further if you need to make it a full Nissen, or leave it a partial fundoplication. There are people that will actually do hiatal hernia repairs and then TIFs. I'm not a big champion of that, but that's certainly being discussed a lot because people are starting to argue that it's more reproducible how they do a fundoplasty with the transoral procedure. I think with good surgical technique, that's a hard thing to argue for, but nonetheless, it's definitely something that you can revise. We've been able to prove that.
Another question that Adil brought up was whether or not the patients who are counseled on experiencing dysphagia and how you manage that with some of these procedures, especially after the endoluminal bariatric and gastroesophageal reflux procedures?
So in our experience, dysphagia is actually fairly low because these are partial fundoplications. They may have some very early dysphagia, but it goes away actually quite quickly. I think what you see with these is these valves are not as robust as a full Nissen valve. They're not 360 degrees. We hope that they're often 270 degrees, but that's an optimistic number, and you can achieve that in certain patients, but not every patient. So the dysphagia rate tends to be very low after these procedures, and it's one of the reasons I think people are interested in it, because rightly or wrongly, there's a lot of folks out there that are very concerned about dysphagia and gas bloat after Nissen, and gas bloat tends to be higher in fundoplication than what we see in these endoluminal procedures. So there's trade-offs that you have to make. You have better reflux control with a stronger wrap that's done surgically with diaphragmatic closure than you do if you do a transoral procedure. But again, patients often don't want those. So it's like bariatric surgery. We operate on 2% of the patient population. So it gets back to what Mike was saying earlier. We need to know how to do these procedures and offer them. And we'll be surprised how many patients come in and actually are interested in it.
In terms of the bariatric procedures, the patients actually like dysphagia. So whether it's a revision where the stoma is reduced or the primary procedures, when the patients can feel something, they actually like it. So I know that some of the procedures out there that don't maybe cause dysphagia are probably, from a psychological standpoint, not going to result in as much success.
Can I add something? Mike, talked about revising the primary sleeve gastroplasty. Interestingly, just 2 weeks ago, I revised one of our own primary sleeve gastroplasties. We redid the whole thing. Amazingly, this patient's 2.5 years out from her first procedure. She's lost 45 pounds, and she wasn't gaining weight, but she was starting to feel much more hungry. And so we rescoped her, and her outlet of her primary sleeve gastroplasty had basically gone to about 4 to 5 centimeters in diameter. But at 2.5 years out, she still has plications in place. And this was not with the Pose device. This was with the OverStitch device, which I think is less robust than the Pose device as it relates to permanence of the sutures. And so we went back and we retightened everything up, and she immediately became more satiated and has done well so far. So I think these are revisable. I think they're convertible. I think it's very interesting if you look at Pose and what Mike showed around Pose and compare it to endoscopic sleeve gastroplasty with the OverStitch device. They're both attacking 2 separate zones of the stomach, which may make them very complementary together. So there's lots of interest in what we can do with these primary procedures because they're both working in different mechanisms. So this is really powerful stuff that can be happening down the road, and we've got to be paying attention.
I know there's a great panel of bariatric experts. Another question I have is, what is the physiologic mechanism behind these endoluminal therapies actually decreasing garrulin? I know with the sleeve, they actually take part of the stomach out. How would you all hypothesize the endoscopic procedures reduce those lab values?
Well, I don't think we know completely why, but there's some theory around fundal stretch, and if we can kind of take the fundal stretch away, that's going to affect the hormones. But this is definitely an area that's still being looked at. I mean, it's interesting in the endoscopic gastroplasty procedure actually didn't really result in much change in a lot of those hormones, but yet the weight loss was much more robust than for example, the Pose procedure. So, I'd be interested in hearing what the other panelists think, but I'm not sure we have a complete grasp of what the hormones are doing and then how our procedures are affecting them.
I don't think ghrelin particularly will go down and stay down. Maybe it drops intermittently, but I don't think it's going to stay down. I think this is a different mechanism that's looking at really kind of potentially maybe how the lap band works, in that it's distension or pressure on the cardia, and that's a neurologic response that feeds back to the brain as far as a sense of satiety. It may be working more on that mechanism. We know from the OverStitch primary endoluminal sleeve gastroplasty data They did this in Mayo. They looked at gastric emptying, and what actually happens with the sleeve gastrectomy is you improve gastric emptying, and you don't do it with an endoluminal sleeve gastroplasty. You actually have food retain in the fundus, which is a different mechanism than pose, but nonetheless, the food retains in the fundus for a longer period of time, probably distending the cardia of the stomach and potentially that providing satiety. But this is all speculative at this point.
Another question I have is in looking at the Medagus muse and the stapled anastomosis in comparison to transoral fundoplication, is there any hypothesized risk of damage to the vagus nerve, and how would that affect the patient postoperatively if that nerve were damaged?
So let me just tell you that there's a possibility of injury to a vagus nerve when you work at the EG junction endoscopically. I think we're learning with some of our POEM procedures that when we create heat or create injury in the wall of the esophagus, occasionally, rarely, there's a suggestion that we may have injured a vagus nerve. And I'm starting to see that in some of our POEM patients where we've really been vigorous, and I think it might be possible when you do some of these interventions at the EG junction.
I agree. We're not recognizing vagal nerve injuries in these patients. We're not seeing a patient crop up on a regular basis that shows gastric distension or delayed gastric emptying as a result of this. I do not know of or can think of a patient that I've done an endoscopic fundoplication on that then postoperatively had delayed gastric emptying or evidence of vagal nerve injury. That doesn't mean it doesn't happen, but the question is how clinically relevant. And at this point in time, we don't have data that really shows that it's relevant yet. But that doesn't mean it's not out there and there's not a real incidence of it. We just haven't seen it yet.
Another question I have is I've heard reports now that the transoral fundoplication actually is helping relieve reflux after the POEM procedure. I wondered if you'd like to comment on that, Dr. Wilson.
It's an interesting concept. I think we're seeing POEM, and Dr. Ponsky can comment on this better, but we're seeing POEM getting more sophisticated in the way it's being done, different approaches, anterior, posterior approaches, trying to reduce the incidence of post-myotomy reflux, and that may change things dramatically. That being said, could you potentially do this? I think you could. I wouldn't probably do it in one stage, obviously, but if the patient didn't have a significant hiatal hernia and they met criteria, it's something worth considering. It's not something I've done yet, but it's something worth considering and is an interesting option. But I think we're going to see POEM actually get significantly more sophisticated in how and get more specific around the myotomy that's done. So the incidence of reflux post-myotomy will continue to go down. I'd be curious to see what Dr. Ponsky says about that.
I agree with you 100%. I think we're in our infancy doing this. We go in there with a sledgehammer and cut all the muscle there, and our goal is to relieve the sphincter obstruction, but then we create reflux, and I think as we learn to do this better, we'll be more selective in what we do in both position and extent and direction, and I think we're going to improve. I also think that I wouldn't do anything to augment the sphincter at the time I'm destroying it. I would wait and see what I have, and then if the patient, when studied or on symptoms, has severe reflux later, that might be something we could go back and do.
This is a final question. As a program director, how should we be training our residents and fellows to better address the changing landscape and evolution of endoscopic therapy?
Who are you asking that to?
To the panel in general. I say that as a program director.
What do you think, Bipan? We can't hear you, Beep. You got us on mute.
I think it's exposure. I think that's probably the most important thing. I think, I think as attendings, we need to first being, embrace these therapies, and I think the panel obviously does that. But I think more and more programs need to have endoscopists, in particular surgical endoscopists. And if you have that, and I think if residents have the opportunity to work with them, they need to recognize that what they're seeing today is what the future is going to be for them. So I think that's the biggest thing, is just exposure and getting the residents involved in these cases. You know, the skills that we're trying to teach them is something that they see in the 5 years, and many of the things that they saw in the presentations today are very easy to learn. The learning curve of these are much simpler than many other procedures that they're going to be doing. So it's not hard. I think it's just getting them exposure and then them wanting to embrace these and recognize that these are going to be the future for them.
Yeah, JAMA recently published an article that looked at once a proven treatment or once a new treatment has been proven to be better than the current standard, how long does it take for that new treatment to actually become the standard? And it's 17 years in this country. And I think we have to change that because, especially as surgeons, if we wait a generation to have our surgeons learn these techniques, we're gonna lose them, and because the patients are going to demand it. They already are. Patients are demanding endoscopic techniques. They're demanding less invasive techniques, and so I think that, you know, if your program has to take advantage, excuse me, of surgical endoscopists if they're not around. I'm sure that there are programs nearby that would be willing to you know, share their procedures with these residents, but I think I'm a bit worried about our next generation if we don't really focus very hard on teaching our residents right now on how to do these procedures, or how to at least just do advanced endoscopy. And again, it's not hard, I think, for a surgical resident to pick up. Most surgery residents come into residency already having some technical skills, or at least a ability to pick up technical skills quickly. So, you know, I just think the programs cannot ignore endoscopy. If they do, we're doing a disservice to our residents.
I'd like to reiterate what Mike said during his talk, which was really about the whole cardiology reference. He is dead on about that. We are looking at the exact same scenario. If we don't pay attention, we're going to go the way of the cardiac surgeons, and all we're going to get is the residual, leftover, revisional, third stage stuff that the gastroenterologists can't find a way to take care of unless we're engaged in this firsthand. So what I would do in my program, and this is what we do in our program, is we throw a scope in people anytime we can get a chance to, and it has some indication. It has to be a decent indication. I'm not talking about, you know, throwing a medical student on the table and putting a scope in, but nonetheless, we need, if we're in the operating room and there's a reason to take a look at what we've just done, throw the scope in and look at it. Manage your own post-operative patients endoscopically as much as you can. Get comfortable with stents, as was talked about. Embrace these devices, learn these devices. Be prepared for your practice to change. But we have to start managing these diseases, which means they're chronic diseases, which means we'll continue to see the patients, and endoscopic therapy, evaluation, all the therapeutics associated with it, we need to be involved with it. And so we've said it many times during tonight, but it just needs to be stressed. And I think that's why you set this whole thing up, Brian, specifically for that reason.
I just want to say one more thing, and that is it's okay to talk about hands-on exposure, and it's okay to keep doing the procedures. Everybody's right. But I think as surgeons, the reason that endoscopy has gone so far is that we've done the inventing. And so we might need to keep innovating and keep inventing the future, because it will be surgeons that invent the future of endoscopy, not the gastroenterologists. They'll just take what we give them. So we have to keep inventing the future.
Good way to end.
Great way to end. Thanks so much for all the resident participants, and thank you for all our expert panel. It's been really a fantastic talk. I really appreciate it.
Thanks, everybody.
Thank you.
Nice job, everybody. Nice job, Brian.
Thank you.